Welcome to Make America Healthy Again. Join Dr. Charles Antonori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antonori.
This is the Make America Healthy Again podcast. I'm Dr. Antonori. Today I have a great guest, my nephew, Paul Carey, who is a orthopedic surgeon, trained all through the U.S. Army system. And we're going to talk about his career, his deployments, and what's going on in orthopedic surgery. I guess mostly hand surgery. And okay, Paul, anything you want to tell us about?
Yeah, sure. I think I'll just tell you a bit about myself and my career, which is a little atypical. Yeah, so I went to West Point for undergraduate, graduated from there in 2004. At that point, I went straight into medical school, along with about probably 20 of my other classmates at that time. And
where'd you go to medical school?
I went to medical school at State University of New York in Brooklyn, downstate.
That's what your dad went to, right?
That's right. Yep.
Yeah.
Yep. And Kings County Hospital in Brooklyn. 4 years. A lot of trauma. I actually did a lot of trauma surgery as a MS3 and MS4. Probably more than anybody else. And so that was very good. Actually, they used to send some of the military reservists there through Kings County Hospital for pre-deployment training while I was there. So saw that.
Oh, that's interesting. I didn't know that. That's interesting. Wow.
Yeah, they had been doing that for a while. Dr. Kurtz was the head of trauma at the time. And so they had a very big trauma surgery program there, obviously, with the need that's in that area. Mm-hmm. And from there, I did a few rotations in orthopedics with them and decided that's what I wanted to do. So applied through, I still had a commitment at that time to the Army from my West Point contract. So I applied to the military residencies and ultimately decided to go with El Paso, Texas, which is William Beaumont, Fort Bliss. Mm-hmm. It's also co-located with Texas Tech University in El Paso. It's like a dual program there.
Is it still called Fort Bliss, or did they change it?
No, it's still Fort Bliss. Yep, it's a huge Army base right in El Paso.
Is that where the Brooke Army formula comes from? The burn formula?
No, that's a Brooke Army Medical Center, which is in San Antonio.
Oh, okay.
At Fort Sam Houston. Which we would actually periodically take trips over to San Antonio. That's the center of Army medicine. Actually, is there at Brooke Army in San Antonio, and so we would do courses over there. And yeah, I did 5 years residency in El Paso, also very trauma heavy. There was the level 1 trauma at Texas Tech, not at the Army Hospital, but at Texas Tech Hospital in the city of El Paso. And
what kind of trauma? Knife and gun from the city, or what?
Well, it was a mix. A lot of highway trauma. I-10 goes right through there. There would definitely some violence down there. El Paso itself is very safe, but it was right on the border of Juarez, Mexico. We would get some spillover from that with everything going on in Mexico. At the time, you weren't actually allowed to even travel to Mexico. Like, it was blocked off because the city itself had such a violence issue.
Wow.
So we would see some spillover from that, gunshots, stabs, various things.
Well, that sounds like really good training. Yeah, I mean,
it was very good, very busy. It was the county hospital, right? So they're taking everything. It's the referral center for large part of the Southwest there.
Right.
Complex hand trauma. We would get a lot of that. We had a great attending there, Dr. Miguel Perella Cruz, who's still there actually. Was a hand surgeon, mentor of mine. He's also an Air Force reservist for many years, and trained under him. And Phil Belmont, who is, I think, now at the CDC or somewhere in DC. But very, very good staff, good group, good camaraderie, good training. A lot of trauma, and then on the Army side, it was a lot of sports medicine. soldier, typical things with soldiers like ACL tears, rotator cuff, labrum,
Uh-huh.
bicep, ankle fractures, wrist fractures, things of that nature.
Mhm.
So it was kind of a split between those two, I would say. Not a whole lot of um, what I see a lot of now, which is the elderly population with their fragility fractures and things like that.
Mhm.
So it was a little unique in that setting, but
That's it. That sounds great. Sounds interesting.
yeah, yeah, no, it was good. So five years there. At the time, I was thinking about doing a spine fellowship, but life kind of got in the way. We had three children during residency, my wife and I,
Right.
and
I know.
and it not that that was the reason, but we just I decided going into fellowship right away wasn't for me.
Right.
So I took my posting up at Fort Drum in upstate New York,
Uh-huh.
and that's north of Syracuse. And we went there, and that was when my first deployment came about, which I could tell you about too, if you
Right.
want to get to that.
Yeah. Yeah. Yes. Might as well do it. That doing in chronological order. So yeah, that the first one's Afghanistan when it was still hot, huh?
Yeah, this was 2013, so it was 10 years in of the whole event.
Yeah.
But that was, my experience with that was that I finished residency, like you normally do in June, and got to my base and got set up. Probably did three cases on my own as a junior attending, and went to Afghanistan. So,
Wow.
so that was three, I think minor cases, and I went to Afghanistan and flew over. I was there in Ghazni, which is a small base in the southeast, which was a NATO base run by the Polish at the time.
Huh?
The Polish were there, the Ukrainians, Americans, and I think that was it. I was on a forward surgical team, like I was on all my deployments, which is comprised of typically two general surgeons, either an anesthesiologist or a CRNA, orthopedic surgeon, OR nurse, OR tech, few medics, and usually one of those people will also double as the commander of the FST.
Uh-huh.
And so it's a small group just
Now, did this
designed.
replace the MASH units, the FST? Is that
Yeah, so so my understanding with that is that there was Defense Secretary Gates came up with this policy that they were going to commit to having a forward surgical team within 1 hour of anywhere where there was going to be combat trauma.
uh
And so that really increased the requirement for these FSTs, the golden hour.
yeah,
So the idea is life, limb, or eyesight, and that's what you're there to take care of.
I see.
As far as the mashes, the way the Army is set up, they have different levels. So your forward surgical team would be your surgeons, and then you'll have like what they call a Roll 2 hospital, which is typically bigger, which would be usually an ER doc or an internal medicine doc or something like that, or
Mm.
two, and they'll have several nurses and techs and lab capabilities.
Uh,
And you're typically not co-located with that when you're on an FST. The FST, you're typically out more forward,
oh wow.
more of an austere
And you
environment.
didn't have lab? You didn't have lab work or
So that first one I was at was no, it was a very tiny base. I think it was maybe 1 mile. You could run around it; it'd be a mile.
yeah.
And we did not have. They had basic labs that they could do blood typing, ABO
Okay, yeah,
typing, and maybe one or two other little things that they could
like
do.
CBC or something like that, I guess.
Yeah,
Hemoglobin.
yeah. I mean, I'm an orthopedic surgeon, so I don't,
Right, I know.
I'm not
I can
enough
tell you a
said on
funny
that.
story about that with one of my orthopedic surgeons, but not right now.
Yeah. But no, there was no other, no CT scanner. The X-ray was just a portable machine that's wheeled in and out with removable flat plates.
Right.
We had, they have our OR was a plywood hut,
Wow.
and the trauma bay had 4 beds, with also like a plywood hut.
Wow.
Um, So you get the idea. But they had peel packed OR equipment, some very minimal implants for me, like external fixator,
Uh-huh.
couple screws and plates.
Uh-huh.
Um, and that's pretty much it. You're there to stabilize and evacuate people to
I
hire.
see.
So it was right off the helicopter landing strip was right there. It was right outside my bed, actually, probably 20 feet from where I slept every night.
Wow.
You would just traumas would come in, you'd stabilize, and then they would go to the higher level of care, which at the time would have been either in Kabul or at Bagram Air Base, where
Uh-huh.
they had basically like modern hospitals. Picture like a small community, very small
Yeah.
community hospital back in the States.
Wow.
Um, so yeah, that was kind of the setup of it. That first experience that was my busiest when it comes to surgery. I was there about 4.5 months, something like that, on the base. We
Yes.
had at least one mass casualty, um, and we did. I did. Gosh, I don't know. I can't remember 25 to 50 cases or something like that,
Yeah.
surgical cases myself in
Wow.
that time period. Um, External fixators, amputations, a lot of washouts and things. Sometimes, you're asked to the surgeons would be in the general. I call them the surgeons. The general surgeons would be in doing like a chest case or a belly case or something like that, assisting each other. And so then I would be the only other doctor there
Yeah.
responsible for caring for all the other traumas that
Yeah.
need to be stabilized. So
Wow.
that was that was an interesting experience.
Did you see many IED kind of injuries?
What I saw a lot, I saw a lot of gunshots. It
Uh-huh.
was mostly the Afghanis
Uh-huh.
that I saw. We did have a few Americans, unfortunately.
Mm.
Um, the one I remember was, I believe it was the Afghan military training academy had been overrun,
Yeah.
and they had, I don't know how many, 100 or 200 casualties or something, and whoever was able to be evacuated to our base did make it, and then they go through a security process and they make it onto the base, and then they were triaged to the Polish or Ukrainian FST or to our FST, and so we kind of split that.
Mm.
Um, they did have to activate the walking blood bank for that to provide enough blood for everybody.
Mm.
Um,
What's
so
the
they
walking blood bank?
so they would call, obviously the critical item in these acute traumas, replacing blood volume, and
Right.
they only carry so much
Right.
on hand at any one time. It's a very critical resource in theater, obviously.
Right.
So each FST is allotted a certain amount. And as you know, with trauma, you could go through 10, 20 units.
Very
So the
quickly.
walking blood bank, yeah, would be activated, and um, anybody, they would pre-screen everybody on the base who was eligible, and
Uh-huh.
they would put out a call for the walking blood bank. Everybody would show up, and our medics would draw their blood, and then the blood would be used right away.
Wow.
Yeah.
Fresh blood like that is really much better than the blood that, in terms of clotting factors and everything like that, right?
Yeah.
Rather than blood that sat for like, with the normal blood Red Cross situation, it sits for a week or two, I think, before it gets to the hospitals most of the time.
Yeah, my understanding is that it's considered the ideal resuscitation
Right. Yeah.
fluid when you're talking about bleeding, and they used to do 1-to-1, PRBC plasma and so on. But the ideal is fresh blood, fresh whole
Yeah.
blood.
Well,
Um,
they probably didn't plasmapheresis or anything like that, so you're getting platelets that work and everything. I'm guessing, rather than fractionated, where you get fresh frozen plasma and you're getting it all. You're getting, I'm imagining it, platelets, fresh frozen, the whole 9 yards, in the blood.
yep, yep. And so yeah, that was an interesting process to see.
Yeah.
You have these young 18 to 21-year-old medics just running basically this whole program, and people
Yeah.
show up that would line up in an orderly way and have their blood drawn, the blood used right away.
Right. Cool.
So I know the general surgeons definitely saved a few people in that way. I remember the last night we were there, they had two Americans that were shot in the chest, and it was the night we were turning over to the next FST. So they happened to actually have four surgeons on hand,
Hmm.
and they were all working for, 8-10 hours, and they did manage to save these two soldiers, I remember. So that was a good one.
Wow. Yeah. Oh,
But
so that was just your first deployment. Good. Yeah.
yeah, that was my first one. And I was definitely well trained to handle all the orthopedic aspects of that. Based on everything I'd just done with 5 years
Yeah.
of residency. So
Well, it sounds like, the fact that you had so much trauma in your training program really was a blessing, for,
yeah,
for, for that situation to get thrown in all of a sudden to that kind of situation. Man.
yep. And it's there's a fair amount of support too. They do weekly trauma calls while you're out there, and they'll whatever cases came in the previous week, you'll do a presentation on anything that's noteworthy. And there's groups from Brooke Army and San Antonio and Walter Reed and other places that will log in and give feedback and critique, and so it was a good experience overall. Everything
Wow. Yeah.
went well. Definitely very interesting.
I bet.
Yeah.
Yeah. And your poor wife was home with the kids.
Yeah. Yep. That's right. Yeah. That was
Yeah, I remember that a
2017. So
little
our
bit.
our kids were 7 and 6 and 4
Oh, they were already
at that
seven,
time.
huh? I thought they were even smaller than that. Yeah. And then what?
Yeah.
Were the twins
My daughter.
last? The twins come last?
Yeah. The twins came in. Um, no, 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 no. I have that wrong. I'm sorry. That was 2013. So my kids were like three,
Yeah.
2, and 1.
Yeah,
Yeah.
that's kind
I
of
mixed up with my second one.
more like what I remember. Yeah. Yeah.
Um, yeah, the twins came in 2016, so that was my second deployment when
Uh-huh.
she had the 5 kids at home at that time.
Yeah. Wow. Yeah. Wow. And that was also Afghanistan?
Yeah, so the second one, that was, so then, I went back. I was in Fort Drum and did a lot of general orthopedics, and then we went to Afghanistan again in 2017 in October, November, also on an FST. I was at that time in Kabul at H Kaya, which is the international airport there in Kabul. It
Uh-huh.
was the one that was, if you remember the Abbey Gate,
Yeah, that
when
one, huh? Wow.
yeah, it was that base. Yep, and also a large NATO base with Australians, Germans, Turkish. The Turkish had a big presence there, and that was a little bit quieter than my previous one when it comes to a trauma perspective, but it was right in the middle of Kabul. We had uh, we had some incoming fire, some rocket. We got rocketed a couple of times. But nobody was really, to my recollection, was seriously hurt on the base
Uh,
through that. It was an interesting deployment. We were at the airport. About a mile away is the green zone in the center of Kabul, which is about a mile away on the ground. But we would take a helicopter back and forth, and I would go back into the green zone to treat anybody that was over there. The State Department was there. There was a lot of embassies had people
uh,
there, and just like routine orthopedic needs. So
the
it was
green zone
interesting to
is a
see.
protected area, basically. Is it?
Yeah, that was a very, very tiny base. It was the helicopter would land like in a little soccer field, and
Uh,
that was probably less than a mile around with walled compound.
uh,
Um, but yeah, it was this. The State Department had a big U.S. State Department had a big presence there. They had
uh,
their own medical assets, but they were, I believe, internal medicine and a
uh,
couple PAs and things. Um, there was a small contingent of Army medics there, and maybe an ER doc. Um, and yeah, it was just interesting to see that that combination of the State Department and the military and all the other embassies that were there.
Right.
Yeah.
Right.
Yeah.
Right. And then you finally get deployed in Iraq, right? Later, even much later. It was like
Yeah.
another 5 years, wasn't it? Yeah.
Yeah. We had my most recent one was 2021.
Yeah.
Yeah, 2021 into 2022. That was in Iraq, at Al Assad Air Base, Western Iraq. I was there about 4.5 months, also on an FST. Um, interesting place, kind of out in the middle of nowhere. It's my understanding it's no longer that was the one that was um, targeted by, I believe it was ICBMs by Iran. You
Yeah.
remember that base? Yeah, that was
Really?
about
Yeah. Wow.
a year or two before I was there.
Yeah.
And um, yeah, it was the Danish were there as well, Germans, American FST, American Combat Support Hospital was there. Um, didn't have too much trauma there. It was relatively slow.
Uh-huh.
Not much going on.
ISIS would have been defeated by that time, or
Yeah, that was ISIS was not in play in that, other than kind of peripherally. I don't think it was much of an issue. My understanding is that the major threat, we would get incoming with drones and rockets there too.
yeah.
Uh, that happened a couple of times, and my understanding is that would be from like Iraqi militias
Mhm.
that were active in the area.
Uh,
As far as I know, that base is Americans are no longer there. I'm not sure,
yeah.
but I know they've been drawing that down for a while.
Mhm.
At the time, Syria was pretty active,
Uh,
um, and there was a few bases and a few medical assets scattered throughout Syria,
mhm.
also in Baghdad, and then in northern Iraq and the Kurdistan region.
Mhm. Yeah.
Um, but
Wow.
yeah, that was my experience. Came through, all three times came in and out of Kuwait. You would stop over in Kuwait for a few days or a week,
Yeah.
going in and going out, and it very very interesting experience to see how the Army operates in these environments, and all the different countries that are active there in NATO, and the companies that are active there providing various weapons
So,
platforms and services and things like that. It's pretty remarkable how much goes into it.
yeah. It sounds great. Just hearing this all is right. I really, I said thanks. I grew up when the Vietnam War was going on, and we were talking before it came on, I ended up not having to go in because the draft ended right as I got out of medical school, basically.
Mhm.
uh, but we talked about trauma. The Army and trauma has been so vital to surgical training. Throughout the centuries. I mean, I think it was Galen back in Rome was one of the first surgeons. I think he was basically one of the first trauma surgeons.
Yeah.
Oh, okay. So anyway, so then when you came out, then you did the fellowship for hand surgery. Is that it?
Yeah. So I was at Fort Drum doing general orthopedics for a while. Thinking about my career and what I wanted to do. As you know, it's very common to subspecialize. The vast majority of people do a fellowship
Right.
now. Was doing a lot of hand already, whether it's hand trauma or carpal tunnel or cubital tunnel and things like that, and thought, the Army actually has a very good training program at Walter Reed. And so I applied for that in 2019, and I started that at 2020 to 2021, right in the middle of, kind of towards the middle end of COVID.
But yeah.
Um, we moved the family down to Washington, D.C., and that was 6 months at Walter Reed and 6 months at Union Memorial Hospital in Baltimore, which is a pretty renowned hand center where it's a regional replant center, and they're very innovative in hand surgery and plastic surgery.
Is that hooked up with Walter Reed, or is it hooked up with Johns Hopkins, or
It's part of, so it's the Curtis National Hand Center, which is affiliated with MedStar Hospital now.
uh,
And yeah, it's right in downtown Baltimore. Busy trauma center.
yeah,
Did a lot of replants there, a lot of replants of fingers and parts of hands. You know,
really? Did you have to
very
do vascular
interesting.
surgery? Did you do
Yeah,
vascular anesthesia?
yeah.
Really? Yeah. So it's
You would be proud suturing
wow.
the
So
dorsal
I'd be
veins on
very
a
proud.
finger.
Those are tiny little blood vessels in the finger. Oh man. What you have to use? Do you have to use a microscope or what?
Yep. Yeah, you use a
Yeah.
microscope with it's
Yeah.
like 27x magnification, and
Wow.
the dorsal veins on a hand, are very thin,
Yeah, they are
but
small. Yeah.
essential.
Yeah.
And no, I really enjoyed that. It was satisfying. Long surgery. I mean, you can easily
Yeah.
do 3 hours on one finger. You can,
Right.
um, depending on how quickly you're moving, but and that
What
it
kind
was
of
also
suture? What
nice.
was the size of the suture that you
It
used?
would, it'd be like an 8/0 or a 10/0 nylon for,
Wow.
yeah,
Wow. Jeez. Smallest we used was like 6.0 and 7.0. We used 5.0, 6.0, 7.0 basically. Because when we were using 7.0, we thought that was pretty small. Yeah.
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 But you
Yeah.
would, as you know, if you shorten a little bit, you can get length into a primary anastomosis or a vein
Yeah.
graft. We did a few of those. You can harvest a vein from dorsal foot if you need to, things
Oh,
like
really?
that.
Yeah. Yeah. Wow.
It was very interesting to work with the plastic surgeons. I really enjoyed that interaction there. That's
Right.
You don't ever get that in other fields.
Yeah.
And it was just nice to get their expertise. Um, and I don't do replants right now in my current practice. It's really at regional replant centers. But very interesting surgery. Be careful with wood splitters. That's what
Yeah.
that's what I took from that.
Yeah, that's it. That's what'll do it, huh? And I know about chainsaws. These chainsaws take off limbs more than fingers, huh?
Yeah, I mean, it was something about the wood splitters that they just really. That was the one I saw over and over again. Maybe because it was clean, and just distal enough that.
When you say the wood splitter, that thing that you put in the wood, the little wedge that you put in the wood.
Yeah, but no, it's like a crank activated stand where you put the log in and pull a lever, and it just
Uh,
deploys,
oh yeah.
a cutting wedge. And
Uh-huh.
I guess if you're not paying attention, maybe you're holding the end of the log or your hand gets snagged in it.
Oh wow.
Um, that was a common one. Wedding ring avulsions, fair
Yeah.
amount of that.
Yeah.
So
Wow.
be careful.
Yeah. So now you're basically doing private practice, mostly hand surgery.
Yeah, I do probably about 80% hand, 20% shoulder elbow.
Uh-huh.
Um,
Or
and
you guys have to take call. You take call for
I
any
the,
emergency rooms, or
no, the only call that I take is for my group. We cover each other's practice
Mhm.
for for whatever comes up, nights and weekends, people's existing patients.
I see.
I being hand surgery is there's a lot of trauma, as you can imagine.
Yeah.
People are always so. What I get a lot of people that were seen in the ER the night before and they come see me the next morning or whatever, the morning
Yeah.
after, bandaged up. So I take a lot of that from the community. Local hospitals and ERs
Uh,
and stuff are able to send stuff to me like that. Um, and
what's the
yeah,
allowable amount of time before before you can operate on them? I mean, how many hours? If it's clean,
yeah.
if it's cleaned
Well,
up, do they put them on antibiotics or what?
yeah. So I mean, a replant, if that's what you're asking, like a finger,
That's
that
right away, right? Yeah.
you definitely want to do that right away. I
Yeah.
mean,
Yeah.
if it's in the evening, early evening, you're doing it that night.
Right.
If it comes in at midnight, the earlier the better. But
Right.
you do have some time. with that. Fractures, the vast majority of them can wait. I mean, it's,
Right.
a week or two, as long as it's a closed injury,
Right.
no neurovascular compromise.
Uh-huh.
Your typical Colles fracture might wait a week or two
Yeah.
before surgery.
Oh, really? Yeah. Is that right? Yeah.
Yeah, that's totally fine. Yeah, you definitely have to be careful. Not everybody's the same. We make space if they have to go more urgently. We make space,
Yeah.
but yeah, the majority, whether it's tendon lacerations or fractures, it can wait until you have the right space and the right team and time and everything.
Yeah. Well, Paul, I
So,
tell you, Paul, we're getting to like around the half an hour or so here. It's
oh,
super interesting. We didn't get to talk too much about the different tracks. I remember we said talking about how like the difference between going through the Army program and private medical school and that sort of thing. But it sounds like we
yeah,
get great training, especially for trauma. Which like trauma. That's why orthopedics and general surgery will never disappear because trauma is never going to disappear.
yeah. It was a very, very interesting experience at Kings County. I decided I didn't want to do trauma general surgery after
Yeah,
that. That was tough.
yeah,
And orthopedics trauma, that's another great field, subspecialty. But decided not to do that. But that's one I do like that about hand, that there is actually a lot of trauma.
yes,
Um, I have a lot of experience with it, and it's interesting.
yeah.
So
Well, thanks, Paul. Thanks,
yeah, you're
really
welcome.
great, very
Yeah,
interesting, especially the whole the deployments in Afghanistan and everything. We never really got to talk about that before. So what's been great
yeah,
about these podcasts, I'm finding out all sorts of things about my family members that I didn't know. Been a lot
yeah,
of interesting experiences if we ever had time to talk about them.
yeah. No, and I'm sure for you too. I could pick your brain, and I have.
Yeah,
So
yeah,
love to
we've
hear
had
you
some.
with
I've had some. I'm happy now, kind of just doing wound care, and I'm still busy. I don't know how I'm staying so busy.
Yeah,
I don't know. I don't know how I got everything done that I do now, and work 60 or 70 hours a week.
yeah.
Yeah.
That's awesome. Well, cool.
All right. Well, say hello to Kate and the kids and everything, Paul.
Will do.
Thank you very much.
All right. Thanks so much, Charlie.
Okay. See you.
Bye bye. Bye.
Bye.